From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Satish Raj, who is Professor of Cardiac Science at the Libin Cardiovascular Institute at the University of Calgary in Alberta, Canada. Today we will be discussing a JAMA article that he co-authored with Dr. Tae Chung titled Postural Orthostatic Tachycardia Syndrome, a Review. This article was published online in JAMA on August 24th, and there's a link to the article in the episode description. Dr. Raj, thank you so much for joining us on this podcast.
Thank you very much for having me.
Before starting, I'd like to mention that during this podcast, we will be using the abbreviation POTS for Postural Orthostatic Tachycardia Syndrome. Your article explains that consensus criteria define POTS as the presence of chronic symptoms of orthostatic intolerance accompanied by a sustained heart rate increase of at least 30 beats per minute, or 40 for adolescents aged 12 to 19 years, within 10 minutes of standing or heads-up tilt, without orthostatic hypotension, which is defined as a decrease in systolic blood pressure of greater than or equal to 20 millimeters of mercury, or a diastolic blood pressure decrease of greater than or equal to 10 millimeters of mercury with positional change. Can you describe the symptoms of orthostatic intolerance that patients with POTS often experience, and how long do these symptoms need to be present in order to meet criteria for POTS?
So orthostatic intolerance can present in so many different ways. Basically, patients feel unwell when they're upright and better when they lie down. The common symptoms that we see in patients with POTS usually include lightheadedness, a palpitation, a sense of their heart racing. People will sometimes describe nausea with this, sometimes more confusion, a feeling of needing to lie down. Shortness of breath can happen as well. That list isn't exhaustive by any means. Over 30 years ago, they defined it in a group of patients that had symptoms for at least 6 months. Over the years, I think the criteria have narrowed a little, so now we accept at least 3 months.
And what are the proposed pathophysiologic mechanisms of POTS?
So this is one of the challenges, that we have trouble in specific individuals saying exactly what has gone wrong. But one of the things that we've found in numerous patients with POTS and multiple studies from multiple centers is that often the blood volume is low. And the reason that might be relevant isn't so much about absolute blood volume, but that can lead to not enough blood getting back to the heart. So a decrease in cardiac preload or cardiac venous return. And we think that in turn, that can then decrease the stroke volume of the heart, the amount of blood it puts out, and an inability to increase that stroke volume can lead to this increase in heart rate to try and maintain a cardiac output. One of the mechanisms that's been shown in a cohort of individuals a while back is called a partial autonomic neuropathy. So nerve damage involving autonomic nerves involving the lower limbs or the lower part of the body specifically. So these patients can have problems in theory with inadequate vasoconstriction, or perhaps more important, inadequate venoconstriction. So the veins where a lot of the blood is stored may not squish properly to get that blood back to the heart. There are patients that have a primary excess in sympathetic nervous system tone. So the fight or flight part of the nervous system that people talk about, that we all have. And some people, it just seems to be on overdrive. And some of that is physiologic adaptation. So if your blood volume is low and you're struggling to maintain blood pressure, the normal response is to increase that. But in some people, that might be the primary driver. So there are really a bunch of different mechanisms that could be involved, and these can involve, one primary mechanism in a patient, but the same patient can also have multiple mechanisms at play that are contributing to these symptoms.
And what is the estimated prevalence of POTS, and who is most commonly affected?
Let me answer the second part first. POTS is interesting in that it demographically affects females much, much more than males. Exact percentages vary depending on the cohort you look at, but I think it's fair to say it's in the 90% range of female predominance. The age of onset can vary. A big survey we did, a patient survey involving thousands of patients, the most common age of onset was 14 years old. And that reflects that there's a large increase in the incidence of POTS that occurs around puberty and in the early teens. But that's not true for everyone. In that same survey, we found that just under half the patients described the onset of the symptoms as occurring after the age of 18. And this reflects, again, the fact that there seem to be different potential triggers for POTS, right? Where, around puberty, there may well be something related to changes in hormonal levels and things like that. But we certainly see patients presenting after a viral illness or after other insults to the body later in life.
And in terms of the prevalence?
Well, this is a tougher one to answer. And the reason it's tougher to answer is that until the last 18 months or so in the United States, there was no administrative code for POTS. And in fact, that's still true today in most of the rest of the world. But in the ICD-10 system, there is a code for POTS now in the US. In ICD-11, there will be one. So right now, if you said, well, how many myocardial infarctions were there last year or were there in the last decade, we could come up with a very good number for you based on administrative data sampling. But that doesn't exist for POTS. So most of our estimates are back of the napkin estimates, really. And from that, I think people have estimated something in the range of 0.1 to 1% of the population, primarily affecting women. And the sense is that that's increased in the COVID era because about 30% perhaps of patients with long COVID or ongoing symptoms after COVID seem to present with a POTS or POTS-like presentation. And so we think the numbers have gone up, but really accurate numbers are not readily available, but that should change in the next 5 years as people do start using this administrative code and we can start going back and looking.
That's very interesting. And just to follow up on that, your article did mention that about 30 to 40% of patients with POTS develop their symptoms soon after an infection. And you discussed COVID, but are there other infections that are associated with POTS? And what is the typical time frame between the onset of infection and POTS?
The answer to are there other infections is absolutely, I think so, right? But one of the challenges, I come back to living in Canada and getting a bad cold or a flu, which is almost always viral every winter. But until 2020, until COVID, I never knew the name of my virus, right? I personally believe it's actually a more non-specific viral finding that can occur with a multitude of viruses. Certainly in this big patient survey that we had done, one of the questions we asked was, in the 3 months prior to the onset of your symptoms, did something happen? Was there a trigger? And most people said not that they recalled, but of the people that said yes to that, about 30 or 40% said they had a viral infection.
And are there other antecedent events that have been described preceding the onset of POTS?
There are many. They're all much less common. It's certainly been described after head injuries. Certainly, orthostatic intolerance can be a big part of a post-concussion syndrome, and some patients do get tachycardia and will end up meeting POTS criteria. It's been described after pregnancy in a few cases. It's been described after other forms of motor vehicle accidents, perhaps even without a concussion, although it's hard to know for sure whether there was a concussion involved. We see a lot of POTS associated with a multitude of autoimmune disorders as well.
Which history and physical exam findings are important for clinicians to elicit when evaluating a patient with suspected POTS?
While there are a lot of symptoms, the hallmark of POTS is that these patients feel much worse when they're upright than when they're lying down. So the history is often of having trouble cooking in the kitchen, right? We don't think of the kitchen as an orthostatic stress test, but if you think about it, it often is, a good chunk of time where you're on your feet for most people. And that becomes very difficult to do. Grocery shopping is another activity. Most of the grocery stores I visit don't have a lot of chairs. And so it can be a good hour on your feet, and that can be very difficult. People will describe activities that they would enjoy doing, simple exercises, not triathlon training or anything, but, going for a jog or walking outside and playing with their kids, and they find that they're not able to tolerate it. So it's sort of the multitude of symptoms like that. The physical findings, really the most important one is a good set of orthostatic vital signs showing that the heart rate is jumping up excessively. And it's such a simple thing to do, but the truth is that in clinical medicine, we don't do orthostatic vital signs routinely, so you have to think about it. You really have to be triggered by something the patient said about the symptoms being worse upright to say, okay, let's do orthostatic vital signs.
Your article also discusses the importance of assessing for use of certain medications and drugs that increase heart rate. Can you discuss this further and which medications are of particular concern?
So drugs like stimulants can certainly raise the heart rate. There are drugs like diuretics, either direct or indirect diuretics that can decrease the blood volume. As I mentioned, that's actually a problem in patients with POTS. That can drive the higher heart rate. And there are drugs that we don't necessarily think of as stimulants or heart rate raising that can do so as well. So, for example, some of the serotonin norepinephrine reuptake inhibitors that have a little more norepinephrine reuptake inhibition, drugs like Cymbalta, can sometimes significantly worsen the tachycardia in some of our patients. Atomoxetine, which is a much more specific norepinephrine reuptake inhibitor, also used for ADHD in North America, can definitely worsen the tachycardia. And one of the ones there's not as much data for, but anecdotally I will share, is that some birth control agents have drospirenone as the progesterone agent. And drospirenone is fairly close analog of spironolactone, right? So it actually has a diuretic effect, even though it's not marketed as a diuretic.
Patients being evaluated for POTS should undergo some testing to exclude conditions that can cause similar symptoms. Can you describe the standard testing that would be performed and what kind of conditions are you excluding?
We do recommend some basic tests. So we want to get a CBC. We want to make sure someone's not severely anemic. We recommend a basic electrolyte panel to make sure there's not a major metabolic disturbance. A basic assessment of thyroid function, so a TSH or a modified TSH, because obviously hyperthyroidism can cause a sinus tachycardia and mimic some of the findings. And it's not in the last set of guideline recommendations, but I would think it's reasonable to get a random cortisol level, because you don't want to miss a full-blown Addison's disease, which can cause the hypovolemia and certainly present with the tachycardia and the similar symptoms. We're not looking for subtle diminishment of adrenal function. We're looking for a cortisol level of 0, and that can sometimes happen. And the reason you don't want to miss it, obviously, is there's a very good treatment for it that can make the person better, both in terms of the tachycardia and the other issues. If you're worried about whether the tachycardia is something else, so, the differential could include something like a paroxysmal supraventricular tachycardia, depending on how the patient describes it. Or if you're wondering if this is actually a cousin of POTS, something called inappropriate sinus tachycardia, then a 24-hour Holter monitor is worthwhile. And being a cardiologist, I think everyone should get an ECG. It's a really simple test, and you can sometimes pick up other things. So we do recommend an ECG. In POTS patients, it's typically normal.
After these conditions have been excluded, patients being evaluated for POTS should undergo positional testing to assess for heart rate changes that occur when moving from lying down to standing up. Can you describe the different methods that can be used for positional testing?
Ultimately, to get orthostatic testing, there are two broad ways of doing it. The simple way that's accessible really to most physicians and even to many patients is to do what we call an active stand test. This involves often using ideally a blood pressure cuff, so you can get blood pressure and heart rate. You can certainly get heart rate from a pulse ox, where someone's been lying down for several minutes, ideally 5 minutes. And then we will have them stand up and get readings at 1 minute, 3 minutes, 5 minutes, maybe 7 or 8 minutes, and then 10 minutes of standing. And you want to record both the heart rate and the blood pressure at each of those readings. The advantage of that is it's accessible, but it's a little less sensitive. Another approach is to do a formal tilt table test. The challenge here is that these are available in autonomic labs and tilt labs, but aren't as widely accessible. The advantage of the tests are that it's a little more structured, and there's the opportunity to do additional monitoring if you want, because it's in a controlled, structured environment. And these two tests are comparable but not equal. So we've actually done comparative studies of the two, and the orthostatic tachycardia, the heart rate rise, is a little bit more robust with a tilt test than a stand test. But if you meet criteria already with the stand test, then you're going to meet it with the tilt test. So I don't want people to leave here thinking you need the tilt test to make the diagnosis, but sometimes if you're close with the stand test and don't quite meet it, you might have met it with the tilt. The other thing is that there's a diurnal variability to orthostatic tachycardia, so time of day matters. And the orthostatic tachycardia and the standing heart rate, which is what's driving it, are a little bit higher first thing in the morning than they are in the afternoon. And so if you do an assessment in the afternoon and you fell just a little bit short, it may be worth repeating it in the morning when you may meet criteria at that point.
And after the diagnosis of POTS has been made, there are some non-pharmacologic strategies that include avoidance of heat, dehydration, and prolonged standing. Can you discuss the recommended fluid and sodium intake for patients with POTS?
Absolutely. So the foundation for the treatment of POTS is based on non-pharmacological pillars, which isn't to say that many patients don't also need drugs, but it's not a drugs or non-pharmacological approach. It's non-pharmacological and then add drugs in patients as needed. And the strategies for the non-pharmacological approach really come back to what I said earlier about what we think is driving the heart rate in many of these patients, and that is not enough blood getting back to the heart. And so the non-pharmacological approaches are trying to get more blood back to the heart. So one part of that is to try to increase the blood volume. So the first step is to try and get in lots of water. And so we recommend in our clinic that patients drink at least 3 liters of water per day. And to do that, I recommend getting a dedicated water bottle that they keep with them all the time. And you know how big the water bottle is, how many times you have to fill it up so they can be sure that they get that water in. We want them to retain as much of that fluid as possible because the goal is to get them to retain the fluid and expand the blood volume. And so we actually advise that they increase their dietary salt intake by about 10 grams of salt, which is a lot. There are 2 professional statements out right now. One said 8 to 10 grams, one said 10 to 12, so we've settled on 10. Now, one of the challenges with that isn't just that it's a lot, but it's hard to count. A lot of our patients like the taste of salty foods. A lot of our patients have low, normal or lowish blood pressures to begin with, so they're not worried about hypertension at this stage in their life. But how do you count? So it turns out a teaspoon of salt is about 5 grams. And so what we're telling them to take is an extra 2 teaspoons of salt. And so we'll often advise patients to measure it out in the morning, put it in a little container or a Ziploc bag that they can keep with them, and add the salt in the bag as opposed to randomly grabbing bits of salt. If patients can't tolerate the salt intake, they won't eat the food with the salt, then there are other options. There are buffered sodium capsules that are well tolerated but a bit more expensive, or electrolyte supplements that have perhaps 1,000 milligrams of sodium that they can take. If they do the sodium, 10 grams of salt is about 4 grams of sodium, and so they just have to count a bit differently. So salt and water are designed to increase the blood volume. But the other problem is that the patients feel unwell only when they're upright, or mainly when they're upright. And so the problem there is gravity, right? Fluid shifts when we stand up from our thorax, from our chest, to below our chest, from where our heart is to where our heart isn't. And so we've done a fair bit of work looking at lower body compression, external compression, to try to decrease that fluid shift. And so we recommend the use of compression tights, high-waisted, basically going from just under the rib cage to the ankles when possible. And there are certainly prescription-grade tights. The challenge with, at least historically, is that they tend to be hot, tight, itchy, and ugly. And compliance in this younger female population isn't great. So more recently, I've gone to more of an athletic wear approach, where the high-end athletic wear for runners or triathletes actually have numerical ratings, often a little bit lower, often in the high teens, but they can make a difference. Now, the challenge is it's summer now, and these tights in the summer cause overheating, and patients don't tend to tolerate heat, as you mentioned earlier. And so our backup plan for that are the use of body-shaping garments focused on squishing from the upper thigh to the bottom of the rib cage, or compression shorts, because really the abdomen and pelvis is the most important area. That's where most of the fluid goes, not the legs. So we discourage the use of socks per se, compression socks or knee-high stockings. We would rather have it go all the way up, or if you need to focus on an area, focus on the abdomen and pelvis. And then the final pillar is exercise. And this is the toughest. And there are some patients that won't tolerate it and has to be done carefully under supervision, especially in patients that also have ME/CFS, or myalgic encephalomyelitis, or chronic fatigue syndrome, where there can be a lot of issues where the exercise causes downstream problems. But a brilliant study done almost 20 years ago now showed that an exercise program that was really focused on aerobic reconditioning for several months improved symptoms and improved orthostatic tachycardia in those that were able to do it. By far the toughest thing to do. It takes persistence. It can take weeks to see improvement, and probably best done with the supervision of a physiotherapist if available to provide that support in that early phase.
You mentioned the structured aerobic training. Can you describe the type of exercises that are generally recommended?
One of the challenges with exercise is when you tell people to exercise, and if you stop and ask them what they would do, it's typically things like running, treadmills, cycling, those elliptical things, right? Things where they're upright. And so you have a patient that's in front of you telling you how poorly they feel when they're upright. And then we're telling them that as part of the solution, we want you to now be upright and then exercise on top of that. And so the challenge is it's usually just not tolerated. They're not able to do it. And so I would say one of the most brilliant approaches that was developed by Dr. Fu and Dr. Levine when they did this exercise study 20 years ago was that they initially forbid upright exercise. And so what they wanted people to use was a rowing machine where you're squatted down and exercising in that position. And it's a great aerobic workout. If they couldn't use the rowing machine, the backups were a recumbent cycle. So the cycles where you're leaning back and cycling, so you're not sort of propped up, or swimming. So swimming has interesting advantages. One, you're usually horizontal, but also the water provides a compression garment-like effect because the water is providing external compression. If you're using the rowing machine or the recumbent cycle, it's important to recognize that most of these machines have a resistance style to make it harder or easier. And in the beginning, I encourage all of our patients to make it as easy as possible. The goal is not to go out hard. The goal is to be able to get in the habit of doing the exercise and build up over time. And really, you want to make it easy in the beginning for them to accomplish that goal because it's tough, right? Exercise interventions in any disorder are tough to do. And certainly in this disorder, it can make you feel miserable in the beginning.
Are there any behavioral and dietary modifications that are recommended for patients with POTS?
Diet's a complicated question. In some cases, there are patients that will describe feeling worse with their POTS symptoms after eating. There is an association, there's some data suggesting that high carb meals may actually make that worse. It's probably a variant of the postprandial hypotension we see in some patients with orthostatic hypotension.
And which pharmacologic therapies can be used for POTS?
So there are different drugs that approach different parts of this problem. So if someone has a very excessive heart rate on standing, sometimes lowering it will help. And that's a little bit counterintuitive because I firmly believe that the heart rate increase is often not the underlying problem. Often the underlying problem is not enough blood getting back to the heart. But if the heart rate gets excessive enough, it starts becoming the problem. The filling time decreases and that further compromises cardiac output and stroke volume. So when the heart rate's very high, lowering it directly can be helpful. And we've had lots of success with low dose propranolol. So I typically would use a dose of perhaps 10 milligrams 4 times a day because it's a short-acting drug. Or more recently, ibabradine, which is a funny channel blocker that's approved for heart failure, but works to modulate the sinus node rate as well without some of the other beta blocker effects that they've both been shown to be effective in patients with POTS. If their blood pressure is on the low side, they may not tolerate lowering the heart rate. They may need those heartbeats to help maintain the pressure, in which case there are drugs that can help support the blood pressure that may be useful. So one such drug is a drug called midodrine. So midodrine is a blood pressure drug that is an alpha agonist. The goal isn't so much to raise the blood pressure, but to get more blood back to the heart and prevent drops in blood pressure when doing other things. And that can have a reflex decrease in heart rate. So the midodrine can actually lower the heart rate, not directly, but through enhanced cardiac venous return. And sometimes we will try to further expand the blood volume. So the blood volume expansion strategy is the sodium and the salt to help retain the water. And we'll sometimes use a drug like fludrocortisone, synthetic aldosterone, to help the body retain the sodium to retain the water. So those are the early line drugs we use. There's a drug called pyristigmine or mestinon. It's on the market for myasthenia, which helps increase acetylcholine levels. And it does lower the heart rate a little bit. And probably in ways beyond that, it can make some people feel better. It also increases gut motility. So we have to be careful. It's a double-edged sword. If someone's prone to diarrhea and cramping, they will not like this medication. But if someone's prone to constipation, it may help their GI issues as well as improving some of their POTS issues.
And your article describes how some patients can experience substantial functional impairment, reduced quality of life, and actually socioeconomic consequences after being diagnosed with POTS. Can you discuss this?
I would modify the question to say most patients actually, I think, have significant functional disability. And perhaps that's a bias of the patients that make it to see me, but I think it's more than just a few patients. So our world is a vertical world. If you can't actually function for more than a minute or two standing, it's hard to get out of the house. It's hard to drive to work. Many jobs involve being vertical. Even what we consider non-standing jobs involve sitting at a desk, and some patients do well with that and some don't. In addition to the symptoms of the orthostatic intolerance, almost everyone is chronically fatigued. And we're not sure exactly what causes that or how to treat that, so it's a poorly treated symptom. And many patients describe brain fog or a subjective cognitive impairment that can affect their ability to work. And so this has negative consequences for schooling. I mentioned that many of our patients develop POTS in their teens. This is an age when they need to be in school, so it's not uncommon, sadly, to hear kids that have had to take time away from school because of their illness, or sometimes even fall back a little bit because of their illness. In school, delay university, things like that. And then it has consequences for work. It's hard to keep a full-time job and sometimes even a part-time job. And these are often people, mainly women, at early stages of their career. And so it has significant downstream consequences, right? If they're not able to work, then that affects your income, that affects your health insurance, that has, a trickle-down effect. And it's a big problem.
And what is the prognosis of POTS?
Just earlier this year, we were able to publish a study where we went back to patients that have been seen at Vanderbilt University in the late 90s and the early 2000s, in the early window after POTS was defined, and conducted a survey to see how they'd done. So on average, they'd had their symptoms more than 20 years from onset to when they filled out the survey. And it was a good news, bad news scenario, right? The bad news is that only one of the 45 people that responded to the survey, so 2%, only one of them actually reported being cured. Only one reported that their symptoms totally got better. The good news is that just under half reported that their symptoms improved. But that wasn't a cure. That was with treatment, often pharmacological and non-pharmacological. They reported that they were feeling a bit better and functioning better. But about half reported they still were quite debilitated and still didn't feel a whole lot better. So I think it's fair to say that these patients don't outgrow their POTS. It's not just going to magically go away if you just give it 6 months or a year. But at the same time, I think it's important to recognize that there are things that we can do as physicians to treat these patients and help them function a bit better.
Before closing, is there anything we didn't discuss in this podcast that you'd like to mention?
I think the challenge with POTS is multiple, right? Part of it was recognition. I think that's improving. Part of it is we don't really understand the underlying mechanisms that are causing POTS in these patients. Part of it is that we don't have great data. In POTS, most of our research comes from small studies, often single-center studies. We're still trying to understand the mechanisms, but we really need to get to the stage where we can get more funding for research to understand both what's going on, but also how best to treat patients.
Thank you so much for sharing your thoughts about this interesting and very important topic. I'm Dr. Kristin Walter. I've been speaking with Dr. Satish Raj about POTS, or Postural Orthostatic Tachycardia Syndrome. You can find a link to this review article we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.